Hello, and welcome to today's webinar, Shingles, Do You Know What Signs to Look For? I'm John O'Connor from Ignites. I'll be your moderator for today's presentation, which is brought to you by Omnicare. You might think that shingles is nothing to worry about, but that's hardly the case. In fact, 1 out of every 3 people will develop shingles at some time during their lives. The CDC recommends that all adults age 50 and older become vaccinated against shingles. During this program, you'll learn more about the shingles virus, complications associated with them, and how to better protect your residents against this viral infection. Joining us today will be Dr. Todd King, who's a PharmD. Todd is the Senior Director of Clinical Services for Omnicare, a CVS company, and a top expert in the field. In just a few moments, you'll be hearing from Todd, but a couple of housekeeping matters need attention. First, the slides will not be available for download today. Are you having audio problems? Please first check the volume control on your machine. If problems persist, click on the Help button in the upper right-hand corner of the player. Also, please note there is no call-in number. Sound will be coming directly from your computer speakers. To submit a question for discussion, click on the button and type in what you want to ask at any time, starting now. We'll try to get to as many questions as possible at the end of the presentation. The National Continuing Education Review Service of the National Association of Long-Term Care Administrator Boards, or NAB, has approved this session for 1 hour of credit. However, you need to stay tuned to this event for its entirety in order to receive a certificate. The CE is only available for those listening live and registered. A certificate cannot be created if multiple attendees listen live on one computer. A link to the certificate will be emailed to you after the live presentation concludes. If you did not receive an email by the end of the day, please check your spam folder. Please be aware that NAB recently changed its process for obtaining CE credits. As of April 1st, all licensed long-term care administrators seeking CEs must provide their NAB CE Registry ID number in their webinar registration form. Ignites cannot verify or report attendance to NAB's CE Registry without this information. To create a CE Registry account and ID number, please refer to the NAB Verify user guide. For this and additional information regarding compliance with new CE rules, please visit them at www.nabweb.org/careregistry. Finally, this session will be archived and available on demand shortly after this live broadcast. You can watch it later at www.mcknights.com/June27. We're very fortunate to be joined today by one of the foremost authorities in this field. As was noted earlier, Todd King is Senior Director of Clinical Services for Omnicare, a CVS health company. He is responsible for overseeing the clinical services for the Southeast and Northeast regions, including managing the consultant pharmacists and clinical managers for the regions, implementing clinical programs, managing facility formulary, and providing education to customers and staff. Dr. King received his Doctor of Pharmacy degree from the Campbell University School of Pharmacy in 1990 and completed a residency in geriatrics and long-term care in Durham, North Carolina. He is a fellow of the American Society of Consultant Pharmacists and a certified geriatric pharmacist. Dr. King participates in programs with the North Carolina Healthcare Association, the North Carolina Assisted Living Association, and the Board of Nursing Home Administrators in North Carolina. Well, Dr. King, you must be a very busy person right now, and we have a lot of ground to cover. Are you ready to get started?
Yes, thanks, John. Looking forward to the presentation today. So thanks for everybody for joining. First of all, I want to thank everybody for jumping on the call, and we're looking forward to the webinar to kind of review some things that, as John mentioned, about shingles and how we can recognize shingles and some of the complications and indications around shingles and how it can be prevented, and if someone does get shingles, how it can be treated and ultimately managed in later in life. So as we go through the slides today, I'm going to talk about several things. And, one of the things that I want to stress today is, we are going to talk about shingles, but we're also going to talk initially about vaccinations. One of the things that I think is extremely important is that we do utilize vaccines, especially in our older population. So if you look at the slide here that I've put up about vaccine coverage for older adults, you'll see in this slide it's pretty interesting that you can see where our opportunities are to vaccinate our older adults. We're going to focus, as we've discussed today, on the shingles vaccine and the shingles prevention, but we're also going to look at this slide some other areas where there probably are opportunities. So this is a 2016 National Health Interview Survey where vaccines were reviewed for adults to see who was getting vaccinated for what. And as you can see here, with influenza, we were seeing about in the over 65 age group, about 70% of folks receiving the vaccination. Pneumococcal, about 66%. That to me seems to be an opportunity to improve that vaccination that does prevent pneumonia. Tetanus and tetanus with pertussis were 58% and 20% respectively. Hepatitis B, about 15%. Once again, in our folks over the age of 50, definitely an opportunity. And then last, the herpes zoster vaccine was about 37.4%. And we'll talk about a little bit later why we think, or why I think, that vaccine utilization and percent utilization was low according to some of the other vaccines that we see on the list here. And we'll talk about some opportunities where we think there are potential situations where we can move that percent up to help protect our older adults from this virus. As we go to the next slide, you'll see some reasons here why we think that there are some underutilization of vaccines. And I think for those of you who are on the call today, you'll recognize these if you work in the long-term care, post-acute, or even the senior living community, and work with independent living elderly residents. There's a lot of patient transfers, frequent admissions, and discharges from facilities, tertiary care centers, nursing facilities, et cetera. And lots of times the records for these vaccines either get lost or they're not transferred in the continuum of care, so where lots of times people are not sure whether they were vaccinated or not. Limited implementation of infection control and immunization policies. One of the things that we hope is that with our focus on antibiotic stewardship and vaccine wellness, that we will see in the future better immunization rates for our elderly population, because all of these vaccines do help prevent conditions that can ultimately cause serious complications or even death. Misinformation or lack of information about vaccines. Many of our geriatric or elderly residents were not vaccinated early in their lifetime. Vaccines have come a long ways through history, and we'll show you some of the vaccine information from the current adult immunization schedule in the next couple slides that outlines the importance of this vaccine protocols that should be administered according to the CDC and other national organizations. And then lack of organized infection control programs. As I mentioned earlier, we do feel that the focus on antibiotic stewardship and vaccine wellness will help forward in the future to move forward with vaccine programs and vaccine initiatives. As I mentioned previously, this slide is kind of a little difficult to see, and it's got a lot of information on it, but I just put it in here because this is the CDC recommended adult immunization schedule for 2018. And as you can see, the ERA does focus here on the zoster vaccines that we'll discuss here in a few minutes. But I thought as a reference, look at all the opportunities here for us to vaccinate our adults and our seniors once they get into the over the 65 age population. The recommendations around influenza, the varicella vaccines, the zoster vaccines, and on we go down the list. I'm not going to go over all these individually. You can reference this on the CDC website, but once again, just reinforcing the fact that it is extremely important to vaccinate our older adults when there are opportunities for them to be performed. So let's shift gears, and as the topic of the presentation had, let's talk about the shingles. And the shingles virus is actually known as herpes zoster or shingles as it's known to the lay public in their nomenclature. But actually the zoster infection results from a reactivation of a varicella zoster virus. That's the chickenpox that many of us had growing up, decades after the initial varicella zoster virus infection. So what happens is, for some reason, we really don't know why, is this virus is reactivated in the body. For some reason, there's a variety of thought processes. Is it based on the immune response rate that happens as we get older, as it decreases, is that what reactivates this virus. When this virus is reactivated, it does cause a series of events. And people always ask the question, well, did you have chicken pox? Did you have chicken pox? Does that predispose, or does that cause you to be at risk for zoster? And the fact is, about 99% of adults, whether they remember it or not, had chicken pox as a child or a young adult. So most people, 99% of the population out there, is going to be at risk for this activation or reactivation of the varicella-zoster virus at some point later in their life. Excuse me. So how the virus presents itself is it's a painful disease marked by a blistering rash. If you've ever seen it, you'll know it. It is a very blister-raised rash that can be it's severely itchy, it causes pain, etc. The pain can be mild to severe and may occur just prior to development of the rash, which is considered to be, it's called a prodrome syndrome. So in other words, the pain happens typically prior to the rash occurring. During the rash, and as or the post-herpetic neuralgia, which may persist for months and years. So post-herpetic neuralgia is a complication of the virus, and it is one of those that is the key thing that we really want to prevent, especially in our elderly population, because post-herpetic neuralgia is a painful syndrome that often leads to other types of medications to manage that pain, and it is really a challenge, especially in our elderly residents who are cognitively impaired or have other types of challenges like that. So I did put this slide in just to kind of hit on a key point about the shingles rash. The shingles rash usually occurs along a dermatome or a nerve area in the body. So it more often than not is single to one side of the body, and it can occur in a specific area on one side. That's a unique factor to this rash and how it appears. As you can see, there are some nerve endings in the face and head area, and when shingles does attack that area or form on that nerve dermatome, probably the most serious complications occur from the shingles when they occur in the face and the eye area. So we need to keep in mind that there are a variety of sites that this rash can occur. So usually if you see a rash that is spread across the whole trunk or the whole back of the person, that's typically not a shingles rash, but it can be a rash that follows both dermatomes, but typically it does just follow one. So let's just give some facts about the shingles. And I think it's important to remember these are numbers, and these are things that really do bring to the forefront how common this condition is. About 1 in 3 persons will develop herpes zosters. That's about 1 million episodes in the U.S. each year. Of those 1 million people that develop it, 1 out of 6 persons 60 years or older will develop post-herpetic neuralgia. And as we talked about earlier, that's the pain syndrome that occurs after the rash is gone and after the shingles have exited the body. This kind of lives in the body thereafter. Most people just have 1 episode in a lifetime. However, we're seeing more often that people can develop a second or third episode. I met a lady not too long ago who had some questions about the shingles and the virus, and she had her second episode, and both of her episodes occurred in the facial area, and she's had visual problems and tremendous amount of pain in her facial area and her neck. So she was very concerned about developing it again, and the facts do say that yes, it can occur a second or a third episode. Age does seem to be the most important risk factor due to the decreasing immune response, and that's one of the reasons why we think this virus does reactivate years later as that immune response does decrease as we age. That's something that we think does actually reactivate the chickenpox virus. There's other folks who are compromised or suppressed immune systems who are at risk for the shingles. These are folks that have cancer, especially leukemias and lymphomas, which directly affect the immune system, those with HIV, and other types of conditions, those taking immunosuppressive medications, i.e. corticosteroids, and those types of preparations also can put someone at risk for the shingles. There are some complications. As I've mentioned, there are some complications associated with the shingles, and the one that we've talked the most about is the post-herpetic neuralgia. And as you can see here, the list of these kind of goes on, and the list of these go on. It's post-herpetic neuralgia, scarring, bacterial superinfections, cranial and peripheral nerve palsies, pneumonitis, encephalitis, hepatitis, visual and or hearing impairment, and ultimately death. So these are serious complications, as you can see from this condition. Typically, folks think about it as a rash that occurs, that you can see a rash and you can see the irritation of it, and it does cause itching. But as you look at these complications are very severe and can have long-term complications. So there's always a question that comes about, is herpes zoster contagious? And I put this slide in here just because that is a common question that comes up, and it is one of those that needs to be addressed. So the question is, it's really not a contagious virus, but zoster lesions contain high concentrations of varicella virus that can be spread, presumably by airborne route, and can cause a primary varicella in exposed susceptible persons. In other words, those people who have never had chickenpox. So that's a potential problem that can occur with this virus. The localized zoster is only contagious after the rash erupts and is only until the lesion's crushed or crust. So that means basically when the virus first starts out, there is a crusting that occurs after a period of time, and the virus becomes less contagious at that point. So as we've kind of gone through the background information regarding shingles and the types of things that can occur with it, we've talked about the complications. We've talked about some of the other situations around vaccines and how they can be utilized. Let's talk about some of the vaccines associated with shingles. We now have 2 vaccines on the market. Previously, the first vaccine that came out was the Zoster live vaccine. This is Zostavax. You're probably familiar with that name. This slide kind of goes over its dosing, its storage, and its administration recommendations. This is a live virus that does not contain any preservatives or anything like that. You can see the dose that's listed here. It's a 0.65 ml dose administered subcutaneously in the deltoid region of the upper arm. Remember, subcutaneously, as we talk about subsequent vaccines and subsequent issues as we go through the slides, because I think it's important to remember some of the differences between these 2 vaccines as we go forward. The Zoster vaccine, since it is a live vaccine, does need to be stored frozen at an average temperature of 5 degrees Fahrenheit or 15 degrees Celsius, negative Celsius or colder. It may be stored or transported at refrigerated temperature and then thawed 72 hours prior to reconstitution. We should store the diluent separate at room temperature in the refrigerator, and then the slide kind of goes through the reconstitution procedure. Both of the vaccines that are currently on the market do have a reconstitution procedure that has to be completed by the person who is administering the vaccine. So it is important as we utilize these vaccines that we do know how to correctly reconstitute them to prevent medication errors that could cause subsequent challenges with the resident or the person who is receiving the vaccine. When you talk about side effects to Zostavax, they are pretty mild. As you can see here, I've listed, the common side effects that occur. These are mild erythema, soreness at the site, swelling or itching at the injection site. These usually affect about 1 in 3 people. Some people have reported headaches after the vaccine, about 1.4%. So overall, pretty minimal side effects associated with the herpes zoster vaccine, Zostavax. So these are pretty well tolerated and generally do not cause any serious side effects or conditions. So let's shift gears and talk about the new vaccine that is actually on the market. The Shingrix vaccine was approved in October 2017. And Shingrix is different than Zostavax in that it is a recombinant zoster vaccine. It's a 2-dose vaccine that can reduce the risk of shingles and post-herpetic neuralgia by upwards of 90%. This is probably the biggest difference in Zostavax and Shingrix that we've seen as it's come to the marketplace. The efficacy rate or the prevention of shingles virus in Zostavax was about 50%. So 50% of the population was protected after they got the dose of Zostavax. As you can see with Shingrix in residents 50 to 69 years old of age, it is effective at about 97% in preventing shingles. So that is kind of the difference that we're seeing with these two vaccines. And it actually has made the CDC and other organizations really change their recommendations around the administration and the vaccination for shingles. I do think also that probably the efficacy of Zostavax was one of the reasons why we did see that lower percentage of vaccinated elderly residents. I think we showed 37.4% in a previous slide. I think that efficacy was probably one of the reasons why we saw a lower vaccination rate in those folks with Zostavax. So as I mentioned, as you can see from the slide, the efficacy of this product has had the CDC and the ACIP change their recommendation and say that the CDC recommends the vaccine for healthy adults aged 50 and older, even if they've had the shingles, already received Zostavax, or not sure that they've had chickenpox. So based on what we're seeing from the data and the preliminary data that this product got approval on, is showing about a 97% efficacy rate in adults 50 to 69 years old, and about a 91% effective rate in adults 70 years or older. So as you can see, those numbers are pretty dramatically higher than the traditional Zostavax vaccine. And then probably as important, as you can see, the Shingrix efficacy effectiveness in preventing post-herpetic neuralgia. About 91% effective in adults 60 to 69 years old, 89% effective in adults 70 years or older. So that's a big key as we talked about the frequency of shingles, and 1 out of 3 adults will get the virus, and then 1 out of 6 of those people will get post-herpetic neuralgia. It is important to note that this vaccine does really reduce those numbers, and we should see a reduction of those numbers as people get vaccinated with this product. As I mentioned, when you look at how Shingrix is administered, it is a 2-dose series that should be administered 2 to 6 months apart. So in other words, you get a dose now, and then you get a dose anytime between 2 to 6 months after that. The second dose should not be given less than 4 weeks after the first dose. A difference in Zostavax is Shingrix is injected intramuscular in the deltoid region of the upper arm. So in other words, Zostavax was a sub-Q injection. This is an IM injection, or intramuscularly, and that is definitely a difference. That when we are educating our staff and people in the community and prescribers and vaccinators, that we need to make sure that they understand that there is a difference in these two vaccines. This vaccine, unlike Zostavax, is stored in the refrigerator at 36 to 46 degrees, and it is a do not freeze. So there are some differences, and there are some things that we need to keep in mind with these products and how they are different. Side effects, possible Shingrix side effects we've listed here. Temporary side effects lasting 2 to 3 days post-vaccine can be common. Most people experience swelling at the injection site. They may, because this is an IM injection, there is sore arm, fatigue, muscle pain. Some folks have expressed a headache, nausea, fever, shivering. Those side effects were reported. I have actually talked to a couple of people who have had the vaccine. One of my colleagues has had the vaccine, and their comments have been that there is definitely some sore arm, and also they did express the fatigue about a day after the vaccine. So, what we're seeing that was reported in the studies that were done with Shingrix is kind of also what we're seeing, at least in the community, from most people that are getting the vaccine. One of the things I think is real important for us to look at, and this information came out early with Shingrix, in February of 2018. Because of the differences in the two vaccines, we have seen some medication errors. And I thought it was important to put this slide in here just to kind of go through and make sure from a standpoint, if we are looking at utilizing this new vaccine, it is important that we educate our staff members, our people who are administering the vaccine, our pharmacies that are dispensing the vaccine, et cetera, to make sure that we understand where the potential opportunities for error are. Because the last thing you want to do is have a new product that actually creates an error, and we have administration difficulties that create problems for the resident and for the person administering the vaccine. So this is data back from October of 2017 when the vaccine was approved up through February 2018. There were about 155 errors presented with Shingrix. About 8% of those were an administration error, and the most common was giving the vaccine subcutaneously versus the intramuscular route. And these led to site reactions. So it's important that we make sure as pharmacists, when we dispense this product, and as pharmacies that administer the product, and as doctors or nurses or staff that administer, make sure that they read the information that's provided with the vaccine to make sure that it's administered correctly. Additional errors occurred when the vaccine was being given incorrectly after it had been frozen, administration of the adjunct component without reconstitution, and therefore administering the wrong vaccine. When you see this product, you'll notice that it is actually in two vials. There's one vial that actually has the product, and then there's one that has a diluent or a reconstitution fluid, and both of those have to be mixed together prior to administration. So there have been a couple errors with the administration of the adjunctive component without reconstituting, and then also some errors around administering the wrong vaccine. Lastly, there's been some instances noted where the patients were not informed that there was a subsequent vaccine to be given, therefore they missed the recommended dosing interval. So as you can see, I think it's important to kind of, as we kind of step back with any new product, it's important as healthcare providers that we really do look at where there are opportunities for us to reduce these types of medication errors. So the authors of this, the Vaccine Adverse Event Reporting Summary, noted that these errors led the publisher to conclude that early monitoring indicates that the vaccine providers might confuse administration procedures and storage requirements with the older Zostavax and the newer Shingrix vaccine. So I do think that this is a really important slide, and I spent quite a bit of time on it just to make sure that we don't have these situations pop up in the future. So as I mentioned earlier, the CDC did update their recommendations in early 2018, and they noted that Shingrix, the recombinant zoster vaccine, is preferred over Zostavax for the prevention of herpes zosters and its related complications, and Shingrix is recommended in separate doses 2 to 6 months apart in immunocompetent adults aged 50 and older. Remember, with Zostavax, the age was 60 and older. So now we are vaccinating people at an earlier age to help prevent, and we've got a vaccine that shows that it helps prevent shingles and its complications for those of us who are approaching or at that 50-year mark. So also the CDC went on to say that persons who reported a previous episode of zoster and persons with chronic medical conditions such as diabetes, rheumatoid arthritis, COPD, chronic renal failure can be vaccinated unless otherwise contraindicated. And persons who are anticipating immunodeficiency due to initiation of treatment or progression of illness should be also offered the Zostavax vaccine also, or the zoster vaccine, excuse me. It is not necessary to ask the patient about their history of varicella or chickenpox or to conduct serological testing for varicella immunity. So in other words, as we said earlier, about 99% of the adult population has been or had this chickenpox at some point in their life, but it's really not important in this process to know whether or not that's accurate or not. We can go ahead and administer the vaccine according to its recommendations. So just a couple other things about zoster vaccine recommendations. The zoster vaccines are not indicated for the treatment of acute zoster. They're not indicated for the prevention of post-herpetic neuralgias in those with acute zoster. They should not be used in the treatment of ongoing post-herpetic neuralgia. We've got a slide coming up that talks a little bit about that. We should not vaccinate persons who are 50 years or younger, and it's not indicated for persons who have received varicella vaccine. Do not administer to anyone with a history of anaphylactic reaction, with a history of primary acute acquired immunodeficiency, like lymphomas or leukemia, those types of things, and then other types of conditions such as pregnancy, tuberculosis, and other type of contraindications, or folks who are taking high-dose corticosteroids. So there are some contraindications to the vaccines, but I think it is important to note that most people over the age of 50 will qualify for this vaccine to hopefully prevent those subsequent shingles infections and then also the complications associated with it. So let's shift gears real quick, and I know those comments have probably stimulated some questions, and we're looking forward to those at the end of the presentation. But the next couple sections, what I'm going to do is just go over first the treatment of active zoster, and then we'll talk a little bit. I think it's real important, as I've mentioned earlier, when we've got these vaccines that do these really great things, as healthcare providers, it's really important to make sure that we administer them correctly. So I'll spend a few minutes here at the end as we go through the last set of slides here, talking a little bit about proper administration of vaccines and proper documentation of vaccines. So if someone does have the active shingles virus, they either didn't get the vaccine or they've actually acquired it from a situation of a reactivation of their previous exposure to chickenpox. There are some antiviral drugs that are approved for the treatment of zoster in immunocompetent patients. And keep in mind that drugs like acyclovir or famciclovir or valciclovir, these drugs are powerful antiviral drugs, but the shingles infection is also a very powerful infection. So these need to be taken and started immediately as soon after the rash appears. So to get the maximum effect of these products, they really should be managed and started as quickly as possible. And typically, as long as the resident gets, or the elderly person gets to a provider, the shingles vaccine, the shingles rash is very distinct. So it's pretty easy to diagnose when you see it, because it is, as I mentioned, it follows that dermatome. It's usually on one side of the body. It's an ugly, angry, blistering rash. So most of the time it can be diagnosed very, very quickly, unlike other rashes that occur, whether they may be from other types of conditions such as, scabies and other types of things that cause rash, or oftentimes do take time to get a clinical diagnosis. This one is one that is usually pretty straightforward, so treatment should be able to be started pretty quickly. Now, as we've talked about, one of the things that happens with this rash is it is extremely painful, and it does itch a tremendous amount. If you've ever talked to somebody that's had shingles and had the rash, they can explain it very distinctly how it felt. So management of pain is very important. I've listed some potential opportunities for management of pain here. Acetaminophen or Tylenol, nonsteroidal anti-inflammatories, antidepressants that have pain properties, opioids, anticonvulsants. Some of the anticonvulsants like gabapentin or Neurontin, Depakote, some of those medications also do have some properties where they help with nerve-generated pain. Capsaicin and other topical anesthetics can help relieve the pain at the topical level. So these are very important during the acute phase of the treatment. And then if someone does develop post-herpetic neuralgia, lots of times they are going to need to be treated long-term for the pain associated, because in some people who develop post-herpetic neuralgia, that pain may dissipate in 2 to 3 to 4 to 6 months. In some people, it stays with them the rest of their life. So managing that pain is extremely important, especially as people age and their cognitive status changes. I've interacted with a lot of people over the last 6 months or so that we've been talking about shingles, and hear these stories with residents who have dementia, and we learned later that they had shingles virus years and years ago, and their pain that we were treating an arthritis type pain or something, that was an anti-inflammatory type of item when we really should have been treated a nerve type pain, which is what post-herpetic neuralgia is. So we treated those folks differently and got them on appropriate medications, and lo and behold, their behaviors changed and improved significantly. So managing the symptoms afterwards and during the acute phase is extremely important to help these folks down the road. So our next section, as I mentioned, is going to go through improving the safe administration of vaccines. I think this is an extremely important section, similar to what we talked about earlier around diagnosing and treating aggressively when shingles does come about. We can also use our vaccines to make sure we prevent it, but we also need to make sure that we administer the vaccines correctly. As you can see here on this slide, the 3 basic steps when administering a vaccine is to make sure you select the appropriate needle based on whether or not the vaccine is going to be IM or sub-Q. Once again, there will be a different needle that will be used for Zostavax versus Shingrix. Locate the appropriate site and then administer the vaccine. And I'm going to walk through just a couple basic things on the next few slides. There's naturally a lot more in-depth items that we could look at. Those of you who are on the phone that are nurses, some of this is going to be a review for you, but I think it is good for us to kind of go back and look at these basic steps and how we can make sure that vaccines are administered safely. So if we pick the site, and I picked the IM site just because we've talked about Shingrix a little bit more today and just wanted to make sure that we find the appropriate place to inject in the deltoid muscle and that's the proper area for successful vaccine administration. So I think it's really important that when we go through and look at these steps that we make sure we know exactly where we should be administering the vaccine. I've given the slide here that actually goes through and teaches. We use this as a teaching tool to look at making sure we pick the right site, and when we look at the deltoid muscle, you can see it here, and keep in mind this muscle does vary a lot from patient to patient, person to person, and in our elderly population, this is a muscle that is still accessible in a lot of situations, so it is the predominant area where we should be administering the Shingrix vaccine and the shingles vaccine to make sure that we are getting the maximum effectiveness of the medication. So it's important to determine that site and area and to pick the thickest part of the deltoid muscle, and that's where we'll be injecting the vaccine or whatever we're going to be injecting. So we want to make sure that we locate that thickest part because the needle needs to pass directly into the muscle. And there are, as you can see from this diagram, a lot of other areas that are potentially hazards around that area above and below the deltoid muscle. There are a lot of nerves in this area also. There's a shoulder joint that if an IM needle does hit that area can cause bursitis or other types of damage to that bursa area in the shoulder. And then below the deltoid muscle, there are a lot of nerves that go down through the rest of the arm and into the fingers and the lower arm area. So it's real important if you are administering this vaccine or are going to be using any type of vaccine that's administered IM, especially in this area, that you follow these procedures and make sure that they're done according to what these guidelines present. Now, the other thing that I think is real important is making sure that when we do have our vaccines and when they're administered, is that we make sure that we document vaccines and document them correctly. One of the things, as I mentioned earlier in the presentation, was, one of the things that are so difficult with our geriatric population is that lots of times we don't know whether or not they've been vaccinated or not because we don't have the documentation. And lots of times our folks don't carry that documentation with them, or they might not remember, they might not understand when they were given the vaccine, et cetera. So these vaccine information statements can really help our residents make sure that they are administered the vaccine, and they can keep that with them to make sure that they're able to document when the vaccine was given, et cetera. So these vaccine information sheets, and I've got an example here on the next slide, but these are opportunities where you can give information about the vaccine. It's important to give the person time to read the vaccine statement and just make sure that they understand, because as we talked about, there are some hazards and there are some risks to these vaccines also, to make sure they understand specifically what's going to happen. Perfect example is we've talked about some of the medication errors and issues that have happened with Shingrix. In the VIS statement for Shingrix, it does explain the fact that you will have to come back and get a second dose of this vaccine to make sure that it is as effective as possible. You want to make sure that in the vaccine information statement that we do record in the chart the date that the vaccine was given. Once again, that's important for tracking purposes because, as you know, some of these vaccines, like the pneumococcal vaccine, have time frames on them that it is important to make sure you know when the vaccine was given. The flu vaccine, maybe not as important because we typically give that the same time every year, but a lot of these vaccines do have some time commitments that we need to make sure that are documented correctly. And then record in the chart the date that the VIS was given. See the bottom of the section. So let's go ahead and look at one of those real quick. This is a sample, and I know it's kind of tough to see on your screen, but this is a sample of the RZV, or the Shingrix vaccine. This is a sample VIS, and as you can see, it kind of goes through, why the person should get vaccinated. It talks about the shingles. You can see if you're looking at your screen there, these are specific recommendations comes from the CDC, and it is their recommendations. There's the slide that I showed you earlier about where the shingles virus does attack the dermatomes in those specific areas. This also outlines some of the risk of the vaccines and the reactions that can occur to it, and then goes through and gives specific examples. It also shows down at the bottom there where you can actually document that the vaccine was administered. So just to kind of wrap things up and kind of give you just a summary of what we've talked about today, we went through and talked a little bit about why our senior population, our folks over the age of 65, looked at some of their vaccination rates with a lot of different conditions. And I think all of you probably saw that there is an opportunity for us to have our elderly residents and those folks participate in vaccine programs. We should be working as healthcare providers on vaccine wellness, to where we can, provide our folks the information that they need around vaccines and make sure that when they are available to them or they're candidates for them, that they're given the opportunity to receive those vaccines. We also talked specifically about the shingles virus, how it's reactivated over years after someone is exposed to it, reminding everybody that about 99% of the people who have adults have had chickenpox before, and remembering that 1 in 3 adults will ultimately develop the shingles virus. We then went on and talked about the 2 available products on the market, the Zostavax and the Shingrix vaccine. Shingrix being a new vaccine that came about in late 2017, had really strong clinical evidence that showed its benefit in preventing a shingles virus and also preventing post-herpetic neuralgia, which we learned was the primary complication of shingles, which causes our residents distress and pain. But naturally, there are other complications associated with this virus that could ultimately lead to death. So we talked about the administration of both of the vaccines and how they're given. We talked about the AICP and CDC recommendations that have recently been updated as early as January 2018 to recommend the recombinant vaccine, or Shingrix, over Zostavax because of its efficacy, starting at age 50 with one dose administered and then a second dose in 2 to 6 months. So we talked about those 2 specific vaccines, and then also spoke about some of the common medication errors that have occurred since Shingrix came out. Knowing that there are 2 available products on the market really kind of lends us to opportunities for administration errors. So I do think it's a great opportunity for us, those of you who are on the phone today and on the webinar, to learn about these errors that are occurring so we can prevent them down the road, because it is extremely important. The last thing we want to do is harm to anyone. And as you can imagine, given a drug that's supposed to be IM, subcutaneously can definitely cause some problems, specifically at that injection site, plus the lack of efficacy of the medication. We then went on and touched on the treatment of acute shingles with antiviral medications, and then also the subsequent help or management of the pain associated with the subsequent sequelae of shingles, the postherpetic neuralgia, the rash, etc. And then lastly, we touched on proper administration techniques real briefly. I just wanted to throw that in there as a reminder that administering the vaccine according to manufacturer recommendations is extremely important to make sure that the vaccine maintains and optimizes its efficacy and its use long term. So with that, I'm going to turn it back over to John and let him kind of open it up for some questions. I hope we've got some out there, and I'll do my best to try to answer those. So thanks again, John. Turn it back over to you.
Great. Well, thanks, Dr. King. Well, if I may use a bad pun, you certainly seem to have scratched an itch because we have quite a few questions here lined up, and we'll try to get to as many of them as we can in the time that's remaining. If I could just jump right in, and first, before I do that, just absolutely excellent presentation, very, very thorough and interesting, and really, really good stuff. Thank you so much. Moving on. So you mentioned that Shingrix is a relatively new treatment on the market, but we're hearing a little bit about how there might be a shortage of this medication. Have you heard anything about that?
Yeah, thanks for bringing that up, John. And for the folks who are on the webinar, we have, and it's been reported in a variety of publications, that right now there is a shortage of the Shingrix vaccine in the United States. And I think it's for a variety of reasons. One, and it's probably the efficacy. I mean, the product has shown great efficacy out there. It is under a lot of demand, and I think that demand has probably surged past the supply at this point. We are hearing that there is going to be a resurgence or resupply of the vaccine here in the near future. I don't know specific time frames, et cetera, but I would encourage people, if those of you are in healthcare facilities, if this is something that you're getting questions about from your residents or your family members, et cetera, let them know that the vaccine is out there. It is available in certain marketplaces, and I would always check with your provider prior to getting a doctor's order for the Shingrix vaccine or going to a local pharmacy to get a vaccine. I would always call to see if they have it, and also make sure that it is in supply before you go to that procedure. The other thing that I think, we all need to keep in mind is this is a 2-dose vaccine. So you get 1 dose and you're going to get a second dose at 2 to 6 months. So we've really encouraged the manufacturer to make sure that as the supply continues to resurface, that there is opportunity to make sure that that second dose is administered also. So that's correct. There is a shortage right now. The manufacturer is working through that. I would just encourage people to check with your local provider to see if they have it before you proceed with the vaccine. So thanks for that question. That's an important fact.
Sure. And another viewer has sort of a personal issue here. He said, my older siblings have had shingles with lasting vision and complications, and he wants to know a couple things. Am I at greater risk for getting shingles, and should I get vaccinated in my mid to late 40s before the recommended age 50?
Yeah, that's a good question. I think if you've got siblings that have had it, I mean, I don't know of a genetic link, but if you've been exposed to chickenpox, then naturally you do have the chance to get exposed to this virus later in life. The CDC does not recommend vaccinating prior to age 50, so that would be a decision that you would need to make between yourself and your healthcare provider. I'm just following the recommendations that they have right now. There's not any data on folks who are less than 50, but that would be a suggestion that I would have a conversation with your healthcare provider to see if that's a route that you'd want to go.
Yep, absolutely. One of our viewers wants to know about side effects and more specifically, how many people get shingles in spite of being inoculated. Are you aware of any of that information?
How many people get okay? So yes. So the data that with Shingrix is, those folks in their age range of 50 to 65, about 97% are prevented. So at 1 million people, we would be preventing. There would be probably of that 97% of those million people would be prevent the shingles. So that number falls pretty small when you're using this vaccine. That was one of the challenges that we had with Zostavax is if you got Zostavax, there was about a 50-50 chance that you would still get the shingles. So that's why I think we're seeing the uptake of this vaccine. And I would encourage everybody to, as you go back through, if you go back through the presentation, look at the slide where it shows the age ranges of preventing shingles and then also the prevention of post-herpetic neuralgia, which, is really what we're trying. We want to prevent the shingles naturally, but the complications associated with it are much more severe.
Indeed. And here's another question. What would you recommend for caregivers who are taking care of someone with shingles but who have not had chickenpox themselves?
Yeah, that always comes up. I think you just really need to be very careful. Remember, we touched on the fact that it's not a contagious virus, but it is a virus that in its active phase, some of the open sores and the open areas can produce that varicella virus, and it's very, very potent. So you'd want to take extra care in caring for those people with making sure that you've got gloves and good infection control procedures and all that kind of stuff. So I would definitely encourage the infection control procedures to follow very carefully. It's really just that time frame that the sores or the rash is open and they have the fluid is exposed. So that's really the time that person needs to be very cautious.
Indeed. And another, I think, pretty good question here. A person wants to know, is it possible to have shingles in other areas, such as the top of the thighs or the genital area?
Yeah, it's usually, the picture that I showed there are key nerve areas that run in the torso area. But yes, as I mentioned, there are opportunities for the virus to present itself in other areas. And we've seen that in folks who are really immune compromised and have other types of issues going on. But honestly, traditionally, the virus is pretty consistent. It forms on those dermatomes in the chest cavity area and attacks those areas specifically. But yes, it can happen in other areas.
Very good. And another good question here: Can people experience? Do people experience more than 3 episodes, or is that sort of the maximum?
Yeah, that's a good one. I'm not. I don't know that one, to be honest. I've heard people that have had 3 episodes. I don't know that I've ever heard anybody that had 4, but I'm not saying it couldn't happen. But yeah, I think I've heard people that have had multiple cases. That happens quite often, honestly. And so I think that's another reason when you look at this, and most people who have ever had the shingles and have any complications with it whatsoever, they're going to get this vaccine because they've been through it and they don't want to go through it again. So I don't know what that specific number is, but I wouldn't say 3 is a magic number. It's just one that we've seen out there.
I see. And this question is obviously from a clinical person in the audience, and I'm apologizing ahead of time for mispronouncing some of the words in the question, but here we go. If a person is non-detected varicella titer, what vaccination would be recommended and why?
Say that again.
If a person, sure. Here's what it says: if a person is non-detected varicella titer, what vaccination would be recommended and why?
Yeah, that's a tough one. I'm not sure on that one. That's one I'd have to get back to that person on. If they'd like to send an email to us, we'd be glad to get back to them on that.
Very good. Very good. Let's see. Here's another Shingrix question. Is the Shingrix vaccine effective for post-symptoms many years after shingles?
No. So that I would say that question is, if someone has had the shingles, they're having symptomology, and maybe it's post-herpetic neuralgia, et cetera. The vaccine does not help that symptomology. The vaccine would prevent a subsequent infection, but traditionally other types of medications would be utilized to manage those symptoms, such as, analgesic medications, those types of preparations.
Very, very good. And we have a coverage question here. One of our viewers wants to know, is Shingrix typically covered by Medicaid and or Medicare?
Well, and that was going to be one of my suggested questions if we did not get it here in the next couple of minutes. So I appreciate the person asking that. First of all, unlike several other vaccines like the flu vaccine, et cetera, Shingrix is covered under Medicare Part D and also under most commercial drug plans. And when I say covered, it means it is traditionally on their formulary. There are certain coverage rates that apply to certain different plans. In other words, some plans choose to cover it and some plans do not. But it is a Medicare Part D drug. D is in dog. So unlike other vaccines, traditionally it can be billed through a resident's insurance, such as a commercial plan, a Medicare Part D plan, or a state Medicaid plan. But as for the group, there are certain coverage issues that can pop up depending on the plan. So some plans will cover it, some plans will not. I think it's always important, if you want to get this vaccine, to call ahead to the pharmacy, make sure they got it, first of all, and then actually check and see what your insurance coverage will be for the vaccine, because it does vary widely. I mean, there are some insurance companies that have some take it based on cost and others take it based on efficacy. So you may see some plans that cover this with a low copay. Other plans, depending on what your coverage is, may have specific vaccine copays. We've seen that. So I would definitely call your provider just to see what the coverage is for the vaccine. But yes, that's a great question. And it's one of the things that is important about this vaccine is that since it is a Part D drug and is covered under insurance, it is available for the general population. It's not something that, they're going to have trouble in a lot of cases. But do call to check and see what your coverage would be prior to getting it.
Absolutely. Great answer.
Yep.
And we're really running up against the clock here, so maybe one or two more questions. And it's unfortunate we have so many, but we just don't have the time. So let me just jump right in on this one. One of our viewers asks, do pregnant staff have any special precautions that they should take when working with residents that have shingles?
No, not if they've been exposed to chickenpox. No, that should be okay. I mean, I think you always want to make sure that you're using precautions and using good infection control policies and procedures.
I see. And what if the person isn't sure if they've had chickenpox?
Yeah, I mean, if they're unsure, they should not work with those residents, in my opinion, and just follow their specific infection control procedures. And keep in mind, a lot of the general population, those folks over the 40 and under, 99%, as we've talked about, have been exposed. So whether or not they remember, lots of times you don't want to take that risk, and I would encourage them not to take that risk if they're not sure.
Yep, absolutely. And finally, sort of our classic last question, if there's one message that you want our viewers to take away from this presentation today, what is it?
Yeah, that's great. I appreciate that one. I think if there is a takeaway, I think the important thing we talked about at the beginning, not to focus completely on shingles, is I think we all need to, as healthcare providers and people that work in this industry, be aware that vaccines are very helpful in our geriatric population. There's a lot of good that comes from them. A lot of our population is under-vaccinated, and the shingles is just a perfect example. We used as an example today, as you saw in the first slide there, and it's probably due to the efficacy of the last vaccine, but about 37% of the population have been vaccinated for this virus. And I do think that making people aware of vaccines and making people aware, especially our population of the elderly folks, that these are available to them. And as healthcare providers, we really need to make sure that when people they have access to these vaccines, and when they should have them, that they do get them. As far as shingles goes, I think we have a product out there. We've made an advancement in the prevention of the shingles virus and also and prevention of its complications. And it's one of those that we need to make folks aware of. And it's a good opportunity, I think, from a clinical standpoint to have a positive outcome for our residents. So I really appreciate the time today and appreciate the feedback, and the questions were great. So thanks again, John.
Sure, and thanks, Dr. King. Just a great presentation. Well, folks, we certainly hope you've enjoyed the last hour or so and found it informative. I know I certainly have. We certainly want to give our special thanks to Dr. King for some great insights and takeaways, and I can certainly say that I learned quite a bit. If you'd like to view this webinar on demand, you can do so. Please visit www.mcknights.com/June27webinar, and June27webinar is all one word. Finally, we'd like to thank Omnicare for making today's event possible. From McKnight's, this is John O'Connor, wishing you a good day.